Headache Society actually outline. And what is the outline? This is which includes the forehead, the orbits, the scalp. It does not usually cover pain that is isolated to the face. And we all agree that headache is a disease, but it may also be a disease on itself. Cover the scope of our discussion. So intracranial structures, we have the venous sinuses, we have the cortical veins, the basal artery, and then the dura. For chest, we have the scalp vessels and then the muscles. We have mucous membranes, the nasal and the paranasal spaces. We have orbital contents. We have external teeth and the gums. It is important to say that the brain is not sensitive to pain. It's anesthetic. So what are the mechanisms of headaches? Mechanisms have been described and includes distension, distraction, or of intra or extracranial arteries or veins. There may also be traction or dura envelope, especially the middle and then the posterior cranial fossa. Can be compression, traction, or inflammation, or trauma to cranial or cervical muscles or bones. Irritation or raised intracranial pressure as well, which will cause headache. Headache can also come out pain from a shared nerve supply. There can be cell membrane abnormalities, imbalances, especially in cases of low magnesium in hemiplegic. There can be plasma protein extravasation. There can be sterile meningeal inflammation. Especially in the case of migraine, where the trigeminal vascular system is also involved. Last but not least, there will be certain neurotransmitters such as serotonin, histamine, substance P, calcitonin, gene-related peptide, endorphins, and then you can all goes about to cause some form of neuroinflammation that also produce headache. Why is it important for us to talk about headaches as primary caregivers? Headache disorders are among the most common after stroke and dementia, ability adjusted life years in 2019. Others, which are characterized by recurrent headaches and are associated with personal and social disability, damage to quality of life, and financial costs. And the domain of our care to our patients as we want to see them in the biopsychosocial model. Only a minority of people with healthcare provider. And these few people that will actually provider, studies make us know that about 84% of them will go to their general practice primary caregiver, and only about 16% will go on to see a neurologist. Placement is important. Headaches also cause constant fear. It damages family life, social life, and employment. And then efforts of coping with chronic headaches also lead to other diseases such as depression or anxiety. So the Center of Headache Disorder, that version 3, which was released in 2018, actually disorders in 3 main groups: the primary headaches, the secondary headaches, the cranial and the facial pain. Today we are talking about primary headaches, so we'll quickly delve into primary headaches. So primary headaches are composed of multiple cause episodic or chronic head pain or discomfort.
Corruption. I think we are hearing that there's some breaks in audio, so Dr. Baba will be using the mic instead of her mic to see whether we can have a sustained audio. Thank you.
All right. Please check if the sound is better. Right. So primary headaches are composed of multiple entities that cause episodic or chronic head pain or discomfort in the absence of medical condition or trauma. And there are 4 types: the migraine, the tension type headaches, trigeminal, autonomic, cephalgias, and then other primary headache disorders. Among these 4, the first 3 are the most common. By way of epidemiology, worldwide, about 3.1 billion people have a headache disorder. And these primary headaches constitute as much as 90%. Some literature actually put it at 98% as causes of headaches, with the remaining 10% being of secondary in nature. Tension type headache is the most common primary headache disorder in the general population, although migraine headaches will most commonly present to clinicians to see, especially in a study done in Nigeria recently. It showed that tension type headaches had a prevalence of 73% compared with 19% for migraine. Primary headache also occur in children and adolescents with a prevalence of 62%. Worldwide, about 1.04 billion are said to have migraine headaches, and is more prevalent in women. There's also an inverse relationship between income level and migraine incidence, with having more money decreasing your prevalence and incidence of having migraine headaches. For cluster headaches, the prevalence is low. We have 1 in 1,000 adults having cluster headaches. It is important for us to differentiate between primary headaches and secondary headaches. This is so because primary headaches rarely don't kill an individual. They are not fatal. But secondary headaches, they are. So recently at the Headache Awareness Week, this flyer was made, and I thought it was important to share it in this lecture. You want to use the acronym SNOOP to screen for secondary headaches anytime we are exposed to a patient with a headache. So for us, we want to look for systemic symptoms such as weight loss, projectile vomiting, headache, neck pain. Is the patient having hypertension? Is the patient immunosuppressed? We want to also screen for neurological symptoms such as one-sided weakness or seizures. You want to screen for onset of the headache as being new or changed, or occurring in a child less than 5 years or in an adult more than 50 years. You want to screen for the onset of the headache reaching a peak intensity within 1 minute. And then also for the progressiveness of the headache, whether it is precipitated by position, by cough, whether pain medications help, whether the patient is pregnant, is in the postpartum period, whether there's papilledema, or whether there's trauma as well. Okay, so the first primary headache we'll discuss this afternoon is migraine headaches. And like I said, this is the one that will present mostly to clinicians in their practice. So it is highly prevalent worldwide and ranked 3rd largest cause of disability among patients above 50 years. It may begin early in childhood, but prevalence increases typically at 1 to 14 years and continues till 35 to 39 years. The prevalence decrease among women after menopause. So though it is noted to be more prevalent in women, it tends to go down after menopause. And then there's also associated increased risk of ischemic stroke, depression, bipolar disease, anxiety, and epilepsy among patients with migraine headaches. What are the risk factors for migraine headaches? So risk factors for migraine headaches actually involve odors, lack of sleep or having an irregular pattern of sleep, exercise, smoking, travel, straining, being under a lot of stress, having neck pain, frequent changes in weather, fatigue, drinking alcoholic beverages, having bright lights, and then just before or during menstruation, especially in the teenage years. And then it's also associated with eating certain foods such as chocolate, orange juice, banana, and then cola drinks. And then sexual activity has also been linked with as a risk factor for developing migraine headaches. There are certain medications that also increases your risk of having migraine headaches, such as oral contraceptives, postmenopausal hormonal therapy, nasal decongestants, SSRIs, and then proton pump inhibitors. So we'll talk about the pathophysiology of migraine headaches, and it has actually been described by 3 theories: the vascular theory, the cortical spreading depression theory, and then the neurological inflammation theory. Initially, it was thought that migraine headaches was actually from the initial vasoconstriction of the vessels of the brain that causes the aura, and then subsequently there's vasodilatation that causes the headache, and then that's really the pathophysiology for migraine. But things have changed with current research and clinical trials, and have shown that because of some genetical factors and some environmental factors, as well as the presence of the risk factors such as impaired cortical spreading depression lead to activation of the trigeminal vascular system, as well as release of certain neurotransmitters such as neurokinin A, substance B, and then calcitonin gene-related peptide. These neuropeptides actually cause, at the serotonin nerve endings, actually cause the blood vessels to vasodilate and also cause a sterile inflammation. And that is what will actually bring out the pain. This theory is much more current and believed to be the main pathophysiology of migraine headaches. So for certain individuals who are genetically predisposed, they will have impaired cortical spreading depression, which may give them an aura, because aura is not always present in migraine headache, or go ahead to activate the trigeminal vascular system, which will now call the neurogenic inflammation and central sensitization and produce headaches among them. So there are 4 phases of migraine headaches. The first is the prodrome, which actually occurs for hours to days prior to the headaches, where the patient will have symptoms such as fatigue, nausea, irritability, they are yawning, they have mood changes. Some of them may actually have increased urine frequency. Then there's the oral phase, which lasts 5 to 60 minutes prior to the headaches, where they have visual disturbances, loss of vision, numbness, tingling, weakness, dizziness. They may have dysarthria with it, and then brainstem aura. Then the headache actually starts, which lasts 4 to 72 hours. It is typically unilateral. It is moderate to severe intensity, throbbing or pulsatile. They have light or sound insensitivity, and then they also will have nausea, vomiting, and this headache is made worse with activity. Then the 4th stage will be the postdrome, which is 24 hours to 48 hours following the headache, where they have mood changes, difficulty focusing or concentrating, they have fatigue, and then they have a residual headache, and then a brain fog. So the ICHD3 actually have 6 categories for migraine headaches, which include migraine without aura, migraine with aura, chronic migraine, complications of migraine, probable migraine, and then episodic syndromes that may be associated with migraine. Of these, the first 3 are common, so I'll go through the diagnostic criteria for them. So how do we identify or diagnose a patient as having migraine without aura? These patients should have at least 5 attacks, and it should fulfill criteria B to D, which includes that the headaches must last 4 to 72 hours. And it should have at least 2 of the 4 characteristics, which is a unilateral location, pulsatile quality, moderate to severe intensity, and then aggravation by or causing avoidance of routine physical activity. They should have 2 of these 4 characteristics. Aside this, they should also have 1 of nausea and or vomiting. They should have photophobia or phonophobia as well. And of course, this whole symptom should not be better accounted for by another ICHD3 diagnosis. Then to diagnose somebody with having migraine with aura, they should have at least 2 attacks and fulfilling criteria B and C. And then the 2 attacks, 1 or more of them should have fully reversible aura symptoms, such as visual, sensory, speech, motor, brainstem, or retina. I'll go about some of the auras that they have. And they should also have at least 3 of the 6 characteristics, which include at least 1 of the aura symptoms spread gradually over 5 or more minutes, or they will have 2 or more aura symptoms that occur in succession. And each individual aura symptoms last 5 to 60 minutes. Remember, we described that in the aura stage. And then at least 1 aura symptoms is unilateral. 1 aura symptoms is positive. That is, it's something they are seeing or something they are hearing, not a negative symptom. And then the aura is accompanied or followed within 60 minutes by the headache. But then we describe people as having migraine with a typical aura. That is when they fulfill this criteria, but the aura is only visual, sensory, or speech. There is no motor, brainstem, or retina aura with it. Then we describe them as having a typical migraine with a typical aura. So for visual auras, they will have things like photopsia, uniform flashes of white or black lights. They may also have scintillating scotoma, where they are actually looking at something and it looks as if a fog has formed on it. They may have dazzling zig-line signs. There's a picture of it up there as in their vision. They may have visual field defects, actually have a tunnel vision as well. They may have, for sensory aura, they may have auditory or olfactory hallucinations. They may have paresthesias, pins and needle sensation, migrating up their arms, coming up their body and lips as well, and all that. They may also have speech or language aura, which they may present as a temporary dysphasia, either receptive or expressive dysphasia. So we describe a subset of them as having migraine with brainstem aura, and they fulfill the criteria of having migraine with aura, which we have discussed earlier. Aside that, they should have 2 or more of brainstem symptoms, such as dysarthria, vertigo, tinnitus, hyperacusis, diplopia, ataxia, and then decreased level of consciousness. And these aura must be fully reversible. Then there's hemiplegic migraine, where there's migraine with aura, but this includes motor weaknesses. So they will have motor weakness with as part of their aura and not have the typical aura, visual, sensory, or speech aura that I described earlier. So for the third group, which is chronic migraine, the diagnostic criteria will be those with headache that lasts 15 or more days in a month for more than 3 months. And that they fulfill the criteria B and C we have already discussed for migraine with aura or migraine without aura. And on 8 or more days for 3 months, they also fulfill all the criteria described earlier. And the patient believes that migraine is the onset of their headaches, and it is relieved by using a triptan or an ergot derivative, which my good friend, Dr. Glover, will talk about later on. So for the second type of primary headache, tension type headache, which I said is the most commonest, there are some synonyms. Some books will call it muscle contraction headaches, stress headaches, or ordinary headaches. This is the commonest type. Everybody at one point or the other may experience it. It's described as a dull, persistent pain, band-like sensation that occur on the head. And it has a vertex localization and associated with shoulder tightness. It usually involves the frontal muscle, the temporal muscles, the pterygoid. It has the sternocleidomastoid muscle is also involved, and then the trapezius. So it forms like a band around the person like this, along this group of muscles for the patient. What is cardinal about it is that sometimes they may have pericranial tenderness, where you actually put pressure on these muscles and they tell you, and they can grade the level of pain and then score it for you. So it begins at any age. It is generally bilateral. The pain intensity is mild to moderate. It is not aggravated by routine physical activity, unlike migraine headache does. It may wax and wane throughout the days and may be present for days, weeks, or even years. Tension headaches are also not associated with nausea and vomiting and are very, very less commonly associated with light or sound sensitivity, unlike migraine headaches. So for mechanism of pain for tension headaches, it is thought that for infrequent and frequent episodic tension type headache, the peripheral pain mechanisms I described earlier are more involved, whilst the central pain mechanisms are more involved with the chronic type of tension type headaches. So what is the diagnostic criteria for infrequent episodic tension type headache? The patient might have at least 10 episodes of headaches occurring less than 1 day in a month on an average, and that amounts to less than 12 days in a year. And each pain should last 30 minutes to 7 days. It should have at least 2 of the 4 characteristics, which includes bilateral location. It has a pressing or tightening quality. It is mild or moderate intensity and is not aggravated with physical activity. There should be no nausea or vomiting and no more than 1 of photophobia or phonophobia. And of course, the symptoms should not be better accounted for by another ICHD diagnosis. To diagnose somebody with frequent episodic tension type headaches, they still fulfill the same criteria I've described, but they should have the headaches on 1 to 14 days in a month for more than 3 months. So they have more episodes of the headaches compared to those with infrequent episodic headaches. Then for chronic tension type headaches, they have it in 15 or more days in a month on an average of more than 3 months in a year. And it fulfills the same criteria. It lasts hours to days. It should have 2 of the 4 characteristics I described earlier. And then there should be no more than 1 photophobia, phonophobia, or mild nausea. It's only in chronic tension type headaches that they may have some mild amount of mild nausea. There should not be severe nausea or vomiting associated with chronic tension type headaches. So the third group will be trigeminal autonomic cephalgias. And this is actually quite common. It is usually unilateral, almost always unilateral headache. It is prominent in the first division of the trigeminal nerve division where it supplies, so V1 distribution, that's where you have this headache. And it is characterized by the fact that these headaches are shorter acting, except hemicranial continua that can go on for some days. So the classic TAC is cluster headache, but there are other types such as paroxysmal hemicranial headaches, where it lasts minutes and the patient may have about 40 times in a day. Then there's also short-lasting unilateral neuralgiform headaches attack with conjunctival injection and tearing. This lasts seconds to minutes, and the patients can actually have 100 times in a day. Then hemicranial continua can actually last hours to days, so they will have it 1 time in a day. And then there's also probable hemicranial continua. These are the ICHD classification for them. So what makes these trigeminal autonomic cephalgias distinct is the prominent nature of autonomic symptoms. So the patient may have ptosis, meiosis, lacrimations, periorbital edema, rhinorrhea, all associated with the headache, which is not prominent with those with migraine headaches. And this overshadows nausea, photophobia, or phonophobia that the patient will have. Basically, the pathophysiology for TACs are actually also poorly understood, but it is believed that there's a dysfunction between the trigeminal, cranial autonomic, and then the hypothalamus, which leads to hyperactivity of the parasympathetic system, leading to lacrimation, rhinorrhea, sweating, and all that. And then hypostimulation of the sympathetic system, which leads to miosis and then ptosis of the eye. The classical example is cluster headache, which is over 90% of them. And it's actually more common in males. It is very rare in children under 10 years. So when you have symptoms like that, you should, it can occur, but it's very rare in children under 10 years. It's more prevalent and peaks between 20 to 50 years of age. And then risk factors such as smoking, including passive smoke exposure, alcohol, head trauma, and genetics all play a role in developing cluster headaches. What is also a fact about cluster headache is that the disease is identified by predictability or periodicity, such that the attacks or the symptoms actually cluster around a particular period of time, hence the name cluster headache. So it may occur soon after sleep, mid-morning or mid-afternoon, late evening, or certain times or seasons of the year. That's when they tend to have this disease. Because this is also a unilateral headache, it is important that we're able to differentiate it with from migraine. So we use the acronym CER, and in that, this cluster headache is side lock. It is almost always unilateral. And then it is also excruciation. It's actually, they describe the pain as the worst form of pain they have had, linking it to childbirth, kidney stones as that experience, compared with migraine headaches, which may be moderate or severe pain. During the attack, you notice that the patient is very agitated, which may not be so in migraine headaches. These patients with cluster headaches are so agitated, they cannot sit. They are actually pointing to where the pain is. They are so restless, and it's actually classic among them. And then also, like I said, it has the periodicity to it. So the regular recurring attacks with circadian activity or pattern is not a case that you see with migraine headaches. For the diagnostic criteria, you should have at least 5 attacks, and they are severe or very severe unilateral orbital, supraorbital, or temporal pain lasting 15 to 180 minutes. They should have at least or both of the following, which include conjunctival injection, nasal congestion, eyelid edema, forehead or facial sweating. They may have miosis or ptosis, like I already described, and also a sense of restlessness or agitation that comes with the headache. Aside these 3 common ones I've described, the migraine headaches, the tension type headaches, and then the trigeminal cephalgias, there are other primary headache disorder that as primary caregiver we should know about, and also try to differentiate from the other 3. So there's ICHD actually groups them under section 4, where we have primary cough headaches, which is a headache that is brought about by Valsalva cough reflex. Then there's primary exercise headaches, which is a sudden or gradual onset, and it actually occurs during or immediately after exercise. You have people that will come and tell you, every time I exercise, I have a headache. So it's really due to some sort of exertion. Then there's primary headache associated with sexual activity, which has a gradual evolution, or it can also be sudden, and then it comes about in sexual activity. Then there's primary thunderclap headache, which is sudden onset headache. It has a maximum intensity within a minute. And this type of headache cannot be differentiated from the thunderclap headache that occurs in subarachnoid hemorrhage. So it's always important to screen for secondary types of headaches when you get a patient with this. Then there's cold stimulus headaches that comes about with exposure with cold, such as inhalation or ingestion of cold substance. There's external pressure headache, which composes compression or traction of the pericranial soft tissues, it's quite common, especially now that a lot of us are wearing wigs and it's caused some sort of band or put some sort of tension on the head. So you get a patient that always comes to see you, I have a headache, and then you should actually ask about it. Then there's primary stabbing headaches where they have pin and needle sensation, jabs and stabs of pain in the head at particular place. Another important type is nummular headaches, where it actually occurs as a small circumscribed area on the scalp where the patient will describe the pain. They sometimes have a coin shape, not more than 6 centimeters. Then there's hypnic headache, which is also called the alarm clock headache. The patient actually wakes up with the headaches and it lasts throughout the mornings and improves during the course of the day. Then the last type is the new daily persistent headache, which starts one day and persists daily thereafter for at least 3 months. What is important is that the patient will usually be able to tell you that my headache started on this particular date, and after that, every single day, I have a headache with it. So among the other primary types of headaches, we can actually group them under 4 headings, such as those that are associated with physical exertions. So the cough, the exercise, headaches associated with sexual activity, or the tender club headaches, that is with some form of physical exertion. Then there are those that are caused by physical stimuli, such as the cold stimulus headaches, the external pressure headaches. Then there are epicranial headaches, such as the primary stabbing headaches, and then the nummular headaches, and then the others. Because they are very diverse, I brought up this chart to help us try to streamline it, because there are 10 of them. So if you are suspecting other primary headache disorder, then you can look at the duration. If the duration is more than 4 hours, then it's maybe more of new daily persistent headache or nummular headaches when you satisfy the other criteria or description I have given. Then if it's less than 4 hours, then maybe the other types. So you may want to probe more in the history to find out whether there are triggers. If there are triggers, then you want to look at cough, exercise, sexual activity. Or if you think the headache is like wakes the patient up from bed, then you'll be thinking more of hypnic headaches and so on. So in conclusion, primary headaches, including migraines, tension type headaches, and cluster headaches, are common and incapacitating conditions affecting millions of people worldwide attending primary care. While the exact causes and mechanisms are not fully understood, research has made significant progress in understanding the complexities of these primary headaches that I'm hopeful that at the end of this lecture you have come to know about. It is crucial for healthcare professionals to stay up to date with the latest diagnostic, which is the ICHD3, and treatment option that my colleague, Dr. Clover, will talk about after my lecture. Thank you all very much.
Thank you very much, Dr. Damboa. It's good to know that not every headache is typhoid and not every headache is malaria. Often than not, at most clinics, whenever you have a headache, and even for most of our clients, when they have headaches, it's attributed to malaria or typhoid. But it's good to know that there are a number of causes of headaches, which is not this. And in fact, they are the most common. As you said, some of headaches are actually the number 3 cause of disability, adjusted life. So we should know about it. And I'm sure Dr. Clover would come in with the management so that at least getting to know about it, you know how to go about it as well. Thank you very much, Dr. Damboa, for this presentation. The presentation will be made available so that those who got lost along the line, I mean, she was mentioning a lot of big words. At least you have the slides just to go through again. And you have any questions, please start putting your questions up so that by the end of the second presentation, we can have your questions. They are here to answer your questions. Don't take it home and try looking through the books. You may never find those answers. Thank you very much, Dr. Damo, again. I'm happy to let you know that we have great partners who partners us for such programs. And we have Johnson & Johnson with us and also Novartis with us. I mean, at least we can give it up for them. They are doing a great job, a good partnership to bring such great presentations to you. Novartis will be giving us a presentation. As I told you, there are a lot of current medications that are available for management of primary headaches. And they'll be coming in with a short presentation on some of the medications that are available. And I'm sure that as Dr. Dotlova goes through the management, that you appreciate some of these presentations that will be given. To do this for us, we have Mr. Wisdom Boa. He's the brand manager neuroscience therapeutic area for Novartis Sub-Sahara Africa. Kindly help me invite Mr. Wisdom Boa as he gives his presentation.
Yeah, so good afternoon to everyone, and thanks to Dr. Nketia for the opportunity to have this conversation. And our conversation is, I think, very short and simple. We saw three basic mechanisms in which migraine occur. And there's one that is very specific. And we have current treatments for migraine. Okay, thank you. So there's one that we are very specific for. And we are going to have a small conversation about a young lady. I think she's a doctor. And she has about 15 migraine days every month. So half of a month is gone, almost gone due to migraine. So 15 days every month, this lady suffers from migraine. She has kids, and she recently missed one of her son's university graduation due to migraines. She had serious headaches, and she couldn't attend the graduation. So we'll walk through the life of the patient as we try to understand the impact of migraine, because the impact of migraine actually is not in hospitalization. Research has shown that 2/3 of the impact of migraine is actually due to absenteeism and then presenteeism, which is productivity. So we are losing more productivity from migraine as opposed to the other conditions where we are scared of the mortality. Migraine actually takes a lot from us. So absenteeism is when the patient doesn't come to work at all. But presenteeism, the person is at work, but because of migraine, he is not able to function. So you can imagine what that takes away from the productivity of the economy. So in Novartis, we did our own internal research, and we found out that out of about 13,000 employees, we had about 1,006 who had migraine. And out of that 1,006, the days lost to migraine was equivalent to around 20,000. And the loss in productivity due to absenteeism, patient couldn't come to work. It cost the company $10.5 million in 1 year. But when it came to presenteeism, because when you have migraine, I'm just imagining maybe I'm a boss in a small photocopy firm. One of my staff comes to me today, boss, I can't come to work. Why? I have the headache. The next day he comes, I'll be wondering, is this guy very, very serious at all? And that is how we downplay the importance of migraine. So due to that, presenteeism is costing us almost 30 million because the associate is tired of asking for excuse. So that the associate comes but cannot perform his or her duties as expected. And presenteeism is actually more expensive than absenteeism. Is there a need for us to synthesize a new migraine molecule like Pasuta? Is there even a need? Because there were some treatments in the day before Novartis decided to synthesize Pasuta for the patient's migraine. So is there a need? Yes, there's a need, because if you look at this, a true vein marker scan, which is a retrospective study which spans over 10 years. Now, what they did was that they picked patients who have had migraine, what they were taking, and then they measured their response after 1 year to find out whether this molecule was effective. So the first line is looking at patients who were on any acute drug. At baseline, they had 83%, or when they calculated it, their response rate was about 83%. After year 1, it had not improved. It's the same. If you look at those on triptans, those on opioids, those on NSAIDs, in fact, some of them worsened as the days went by. So after year 1, they had not really improved from the medications that they were taking for their migraine. So this is why Novartis decided that, okay, let's enter the lab and then give you Pasuta. So this is a very short video on our new molecule, Pasuta, which is a monoclonal antibody for migraines. Let me see if it will play well for those online. My audio. Okay, so let's do without the audio so that we'll also save some time. So basically, Pasuta is a monoclonal antibody. And like we said earlier, one of the pathways is the CGRP pathway. So Pasuta focuses on the CGRP pathway. And the audio and the video stresses that when they introduced CGRP in mice, they were able to elicit some migraine-like symptoms, which actually shows that CGRP actually triggers the patient to have a migraine. Also, when patients had migraine, their levels of CGRP were about 3 times higher than ordinary patients. So also showing that CGRP is a very key player in migraine. So what do we have? We have Pasuta, which is erenumab. And Pasuta was specifically designed for migraine. What that means is that up until Pasuta was discovered, all the drugs that were used for migraine, you talk about the beta blockers, everything was not specifically designed for migraine. That's how come you will not be able to elicit that response that you want. I think as they were being used, then you will find out that, oh, this drug can help patients with migraine. But Pasuta was specifically designed for patients with migraine prevention. So that's number 1. Number 2 is that we have other human monoclonal antibodies. Pasuta is the first on the Ghanaian market now. And then it is the only one that is an antagonist to the receptor and not CGRP itself. And the benefit is that because we have other CGRP-like receptors, you would also want the CGRP to act on those ones to have beneficial therapeutic effect. So Pasuta binds, or it is a receptor antagonist only to the CGRP receptor. Then it's a full human monoclonal antibody. Basically, for the monoclonal antibodies, they're able to elicit some immunogenicity. But for those that are fully human, the risk of immunogenicity is very low because it mimics that of what is already in the body. Then it has, it lacks affinity for the other receptors, which I mentioned, like the amylin receptors and then the calcitonin receptors. So only CGRP, and then the patient would be fine. And then this has an effective half-life of 28 days. Basically, what that means is that once the patient takes a jab, the patient will take another jab after 28 days, unlike the acute drugs or the drugs that are currently used that the patient will take every day. So is there data to support its efficacy? The answer is yes. There's so much efficacy data, but we'll talk about just a few of them. Pasuta is for migraine prevention. So that means that when you have diagnosed a patient of either episodic migraine or chronic migraine, that's any patient who has more than 4 migraine days a month, and you want to initiate Pasuta, then you want to reduce the number of migraine days the patient has every month. So for those with episodic migraine, Pasuta has been shown to reduce migraine days by 50% in about 43% of the patients as at in 4 to 6 months. So within the first 4 to 6 months, the responder rate is 50%. And in migraine, what you measure really is responder rate, whether you are getting your 50% responder rate, 75% responder rate, or 100% responder rate. So for the 50% responder rate, patients on either 140 or 70 milligram, you can see 50%, 43% versus placebo, which was around 27%. Also, at 1 year, you can see that about 2/3 of the patients had 50% reduction in their migraine days. So at 4 months, you are having about 43% patients getting that. But after year 1, when the patient had taken Pasuta every month for year 1, you are getting about 2/3 of the patient getting 50% reduction in their monthly migraine days. Then also at 16 months, you are getting 25% of the patients having 100% reduction in their migraine. That means that the patient do not have any migraines at all. So that is the efficacy of patients with episodic migraine. When it comes to chronic migraine patients who have greater or more 15 days or more in terms of migraine days, Pasuta is also effective. So these are the patients that we would usually classify as difficult to treat. And you can see whether the patient is taking a preventive treatment or not. Whether 1 or 2, you can see Pasuta is still effective in these patients across the spectrum. Whether there's no treatment, he's taking greater than or equal to 1 treatment, or greater than or equal to 2 treatments. Pasuta is still effective than placebo or standard of care, which the patient has been taking. Now, when it comes to what we discussed earlier on, which was absenteeism and presenteeism, which is really what we classify as quality of life. Can the patient still function? Is the patient able to go about their normal activities without any impact from migraine? If you look at the first graph, you will see that Pasuta greatly also reduces absenteeism and then also reduces presenteeism. Like I said, absenteeism is when the patient doesn't come to work at all. Presenteeism, he comes, but he's not able to function. So the patient's quality of life are greatly improved also versus placebo as well. So we have about 5 classes of patients, or 4 here, who may need Pasuta. One is the number of all patients whose migraine attacks significantly impact on their lives, despite receiving acute medications. That's one. The number 2 is patients whose reliance on acute medications put them at risk of medication overuse headaches. So there are patients who are always taking medications and then they are at a risk of medication overuse headaches. Then any patient who has greater than 3 migraine days a month, I say moderate or severe headache days a month, when acute medications are not reliably effective, you would want to consider starting the patient on Pasuta. Then, of course, patients who have more than 8 migraine days or headache days a month, even when acute medications are effective, this is to prevent them from tilting into medication overuse headaches. So Pasuta is also indicated for these patients as well. So these are the 4 classic patient types where you can use Pasuta for. Then, of course, the other angle is about safety. So we'll discuss safety using the HEMIS trial. And this was the first phase 4 trial, which compared Pasuta to what is being used real life. So HEMIS is the head-to-head study of Pasuta versus topiramate in a real-world settings, and that brought out the efficacy. So this was done in about 82 sites, and then it was a double-blind study, 24 weeks, and then the primary endpoint was those who discontinued treatment due to adverse events, whereas the secondary endpoint was now looking for efficacy. How many patients had 50% responder rate? So we'll not go through this. Let's go through what the researchers found out. So basically, comparing Pasuta to topiramate, the researchers realized that almost 38%, 38.9 patients discontinued the topiramate due to adverse events, whereas 10.6% discontinued Pasuta due to adverse events. And basically, the researchers said almost 4 times more patients discontinued treatment with topiramate due to adverse events compared to Pasuta. So when it comes to continuation rate or adherence rate, Pasuta also offers you better. And then also versus standard of care at the time, when it comes to discontinuation rate, you realize that topiramate was hugely discontinued while Pasuta was hugely adhered to. Then when it came to efficacy, which I said 50% responder rate, you realize that Pasuta also delivered strongly, where about 55.5% of those involved in the trial had 50% responder rate. Basically means that 55.5% of the patients had their migraine days reduced by half. So also showing that Pasuta is very strong when it comes to efficacy for the patient. And the researchers also said patients were almost threefold more likely to reduce their monthly migraine days by 50% or more with Pasuta versus topiramate. So this also measured the quality of life. And then the researchers also said patients reported a greater improvement in quality of life with Pasuta compared to topiramate. Basically, when you initiate the treatment, you want to, of course, improve the quality of life of the surviving patient and also try and avert mortality in the other arm. And Pasuta is one that greatly improves the quality of life of the patient. So good safety profile with Pasuta from the HEMIS study. And then these are some of the side effects. And we say most of them are placebo-like. If you look at the common side effects, nasopharyngitis, upper respiratory tract infection, if you compare placebo, Pasuta 70 milligram and Pasuta 140 milligram, you realize that most of the side effects are very, very similar. So we say the side effects are placebo-like when it comes to comparing the side effects of Pasuta. I think constipation was one of them down there, was also reported. And if you watch, it was the 140 that had more patients getting the constipation. Now, I think this is my last but one slide. So this also talks about adverse events or benefit risk profile in number needed to harm. Number needed to harm. Comparing Pasuta, topiramate, and then other molecules like propranolol. So if you look at Pasuta 70 and Pasuta 140, for the 70 milligram, you need a larger number of patients to cause one harm in those patients. You need about 1,000 patients to take it to cause one harm in those patients. Whereas for topiramate, you may need only about 21 or 13 in different trials to cause one harm. So it means that you need larger pool of patients. So it is more safer in a larger pool of patients as compared to topiramate. Also comparing it to propranolol, in Pasuta, you need about 1,000 number of patients to cause harm in one patient. Whereas in propranolol, you need only about 11 patients to cause harm. So that means that Pasuta, compared to these standards of care or these molecules that we have used, also comes strong when it comes to this. It's metabolized by cytochrome P450, and then I think the pharmacokinetics usually do not affect oral contraceptives. We focus here because we know that migraine is more common in women. So this would usually come out. And most of the oral contraceptives are the ethinyl estradiol and their derivatives and some progestin. So it's also, it was used concurrently with it, and then it didn't cause any harm. So this is how Pasuta looks like. You have your 70 milligram on the left, 140 milligram on the right. And when it comes to safety and efficacy, most of the data put the safety and efficacy on the same pedestal. So 70 milligram, 140 milligram, similar efficacy, similar safety. However, based on your response or based on what you want to achieve, then you want to initiate 70 or 140 milligram. I think what we've been able to achieve in Ghana is that for some of the conversations, some of the doctors usually initiate based on the body weight. When they have those who are a bit large, then they want to initiate the 140. If they want, if they see the slimmer patients, then they'll go for the 70 milligrams. So don't be scared between the two of them. Each of them delivers the efficacy and then safety that you want in the same measure. Just that you would need to decide how you initiate it for them. Then we also have vote fast. This is my last slide. And then vote fast is for acute management of migraine. So the patient has migraine today. Pasuta is for prevention. Do we inject Pasuta in pre? No. We give vote fast to the patient. And vote fast, you can see these women all shouting that they will not let pain destroy their lives. So vote fast wins every woman in pain, and it starts working in 5 minutes. So when the woman or when the patient sees the migraine progressing, then you quickly mix one sachet in the half glass of water and take it. Thank you very much. For those who need Pasuta, you can call my number.
Thank you very much, Wisdom. I mean, as we're talking, I heard people asking, hey, Charlie, I didn't know bed. So put the question will be coming after. So I said, no, I know. That's what I'm saying, that as we were talking, I realized that somebody was typing the question. So please get ready for me on that question. Thank you very much, Wisdom. Thank you very much, Novartis. I mean, it's good that there are new medications coming up that give us options in terms of management. And we really appreciate that one. But get ready because I can see a lot of people putting up questions for us. Next to speak will be my good friend, Frida Glover. I must say that unfortunately, Frida, I mean, is enjoying herself at Casablanca. Her flight, unfortunately, couldn't bring her to us today, but she's on with us and she's still going to present. Frida, I really appreciate it. Frida Glover is a senior physician specialist and a neurologist. She is a fellow of the West Africa College of Physicians, and she works at Kolebu Teaching Hospital. Her interest is in headache medicine. So you can understand why she's the one giving this presentation. She also has interest in general neurology and demyelinating disorders of the central nervous system. She'll be taking the topic current trends in the management of primary headaches. Before she comes in, there are some interesting case scenarios that will be read to us. I mean, unfortunately, this one it's not part of the one that we are going to mark, but so don't be afraid when the questions have been read. I'm not going to point and ask people to answer, but as she goes through, just get to know these case scenarios that we have. As she goes through, you appreciate it. And at the end of the presentation, I will not be pointing, but people will be answering some questions. Thank you very much. So Dr. Kwabla will be going through the question with us. Please, you can take your pen, your paper, and get to know these questions before Dr. Glover comes in.
Okay, thank you. So these questions are credited to Dr. Peter McAllister of Practical Neurology. So case 1, Jamie's ever-present pain. Jamie is age 46 and married with 4 children. She reports no headache history until 2 years ago when she developed attacks of sharp, severe pain about her right eye, often radiating to the temple and occasionally down her right posterior neck. In fact, certain neck positions seem to trigger an attack. Rarely, her pain would start in her right upper teeth and gums. Initially, she said the pain was present all the time, but detailed probing revealed she averaged 20 to 30 severe pain attacks of 5 to 10 minutes per day. Between these, she had a dull, bruised sensation. Jamie denied autonomic features, but when I viewed photos of her during attacks, I could make out subtle right eyelid edema and droop, but no conjunctival injection. Jamie denied nasal congestion. Every now and then, she was pain-free, but that never lasted more than a few days. Jamie had seen a neurologist who diagnosed her with chronic migraine and prescribed propranolol, 20 milligrams twice daily. After Jamie experienced severe hypotension while taking propranolol, her treatment was changed to zonisamide, up to 150 milligrams daily, but this was not effective and was discontinued. Finally, onabotulinum toxin A injections, 2 cycles of 155 units were tried, also without success. So that's the end of case 1. And now we'll move to case 2. So case 2 is Lloyd's countless lacinating attacks. Lloyd is age 39, lives with his partner, and works as a television news producer. Referred by a local neurologist for potential enrollment in a study on chronic cluster headaches treatment. Lloyd said his headaches began 6 years ago as lacinating shocks of pain exclusively on the left upper face, eye, and temple. His left eye felt scratchy and raw, as if sand had blown into it, and the white of the eye looked crimson and watery more often than not. Lloyd's pain would last 5 to 30 seconds and occurred countless times per day. As he sat across from me, Lloyd would stop mid-sentence and wince, eyes shuttered, then resume talking. He told me his primary care doctor diagnosed trigeminal neuralgia, and when he did not respond to carbamazepine and gabapentin, referred him to a neurologist. The neurologist diagnosed cluster headaches, and after unsuccessful treatment trials with verapamil and sumatriptan nasal spray, referred Lloyd for possible enrollment in our study. That's the end of case 2. Thank you.
Thank you very much. I think as he was reading through the questions, I could, hear the National Science and Maths quiz contestants actually trying to tell me the answers, but we'll see whether the answers are right after the presentation by Dr. Glover. Please, Dr. Glover, let the presentation flow.
Glover. I'm a neurologist at the Preventive Teaching Hospital, and today I'll be taking you through the current trends in the management of primary headaches. So for a brief outline, we're looking at the principles of headache management. Then we'll dive into the management of the various primary headaches, and then look at a particular type of facial pain that is very common and presents to the primary health physician quite a bit often, but the diagnosis can be difficult. So in terms of principles of headache management, our main goals are to relieve the pain, to improve function, improve the quality of health of the patient, as well as manage any comorbidities that the patient may have. Now, it's important that we make a correct diagnosis when the patient comes with symptoms of headache, and that includes ruling out secondary causes of headache. It's very important because if we don't, then we may be setting them up for really bad outcomes. So in terms of primary headaches, it's important to know the characteristics of the different types of primary headaches so that a correct diagnosis is made. When a wrong diagnosis is made, it is very certain that the wrong treatment will be given, and this leads to loss of confidence in the healthcare system. The patient ends up doctor shopping or finding alternative treatments which may not really be beneficial in the long run, leading to increased morbidity or even mortality. The principles of healthcare management involve education, and more education. So it's a 3-tiered approach. We are looking at educating the healthcare provider. So doctors, nurses, pharmacists, psychologists need to know about headache disorders. They need to know how to treat these, okay? And then the patient needs to be educated about their specific headache disorder that they have. And then the society at large needs to be educated about headache disorders, when to pick up what is likely to be a secondary headache disorder, when to report early so that the right interventions can be given. In terms of pathophysiology, Dr. Dalmore has already taken us through this. So in summary, we are looking at the trigeminal vascular system, a trigeminal cervical complex, which connects the trigeminal vascular system through the spinal cord. So we are looking at the cranial, the first and second cervical nerves, okay? And then there are also rostral pain processing regions within the brain, as the brainstem, the thalamus, and the cortex. The hypothalamus has been hypothesized to be involved because of the circadian rhythm of some of these primary headaches, as well as the trigeminal autonomic reflex, which is responsible for the autonomic symptoms that patients present with. So it's a brief summary of all the mechanisms that we have spoken about. Now, there are certain neurotransmitters that are also involved, okay? First of all, usually the person must have that genetic susceptibility or hyperexcitable brain to have the kind of primary headache that they have. Then we see that cortical spreading depression is a recognized entity in migraine, where there's a wave of depolarization starting from the occipital region, moving anteriorly, and this has been seen to be associated with vasoconstriction, and usually it's also associated with the aura that patients with migraine with aura, especially the visual aura, experience. Then there are also these hormones I spoke about earlier. We've gone through the TGRP, substance C, etc. Right, so let's delve straight into the management. And when it comes to management, we are looking at non-pharmacologic treatment as well as pharmacologic management. In terms of non-pharmacologic management, education is important. Like we said, it's the primary thing that we need to do, but we also need to get our patients to keep a headache diary. Now, this diary is just a simple calendar. It can be an app on their phone, it can be a calendar that they hang in their room, or it can be a book where they record their headache. What we want them to do is to mark off the days in the calendar where they have the headache. They need to describe the severity of the headache on a visual analog scale from 0 to 10. They need to say or document the side where they're having the headache, whether it's right-sided, left-sided, if it moves or changes between sides. They need to be able to tell if there are any associations, nausea, vomiting, if they have sensitivity to light or noise. They need to be able to say whether they had any aura associated and document these aura or describe them, because they might not know what exactly that aura is called. Then once they're keeping the diary and they've kept it for about a month, 2 months, 3 months, they're able to identify patterns, and those might show whatever triggers they have. It will be good if they are able to document in the diary also the meals that they're having during those days that they're having the headache, because we know from the literature that certain foods like chocolate, wine can precipitate or trigger these headache attacks. Then for females, it's also good while they are keeping their headache diaries to document their menstrual cycle as well, because sometimes females can have menstrual related migraines especially. So once we know there's appropriate treatments that can be given to these patients. So once they identify their triggers, they must be encouraged, counseled, supported to avoid the triggers as much as possible, and maintain a healthy diet, regular exercise, have a regular sleep pattern, avoid excessive acute changes in their stress levels, avoid alcohol and caffeine in excesses. So we'll delve right into tension type headaches. Now this involves infrequent episodic tension type headache, which is usually 1 or less attacks per month. The episodic tension type headaches, frequent episodic tension type headaches is between 1 and 14 a month, and then the chronic tension type headaches as well. So with tension type headache, it tends to be the commonest headache presenting to the physician, but usually they don't have so much disability. When it's chronic, they can have disability. So the treatment involves both acute or symptomatic management as well as preventive or prophylactic management. Usually, most people with tension type headache respond to the simple analgesics. So we are looking at paracetamol, acetaminophen, 1,000 milligrams, ibuprofen, 200 to 400 milligrams, diclofenac, ketoprofen, naproxen can be used. Now, it's important to stress again that it's always good to take medications very early on at the onset of the headache. Okay, so within 15 minutes of onset of the headache, they can take these medications, and also depends on the severity. Usually for tension type headache, once the patient takes it and the headache is gone, they don't need to keep repeating the doses. Okay, for prophylactic therapy, this will usually be beneficial for those who have frequent episodic tension type headache or chronic tension type headaches that are debilitating, affecting their function. Then we can give them some prophylactic medications. And of these, amitriptyline is the most commonly used. So we start low and we go slow, from anywhere 10 to 75 milligrams per day, titrating against their side effects. Okay, and mirtazapine can also be used. Right, in terms of migraine management, we look once again at abortive or symptomatic management and then preventive or prophylactic management. Judicious use of appropriate medications is very important when it comes to the pharmacologic management of migraine. It should, as much as possible, be individualized. There is an approach to treatment in migraine known as the step ladder approach, and there's also the stratified approach. The step-ladder approach is where, regardless of the severity of your headache, once you come in, you are started on simple analgesics to see whether you respond. And if you don't respond after about 2 or 3 trials, then an opioid can be given or a triptan can be added. And then if you are still not responding, a prophylactic medication can be considered. Whereas with a stratified approach, we are individualizing the therapy. So you look at the patient as they're presenting, how severe the headaches are, what are their comorbidities, and you decide whether you are starting with prophylactic medication in addition to the acute or abortive medication. And acute or abortive can either start from an opioid, to be a very specific therapy like a triptan, or it could be a simple analgesic like paracetamol or aspirin. The ideal abortive medication should have minimal side effects, it should have little requirements for repeated dosing, it should provide complete or near complete relief from pain, and there must be freedom of distraction of their daily or routine activities as well. The 3 major pharmacological classes of medications that are used when it comes to acute treatment of migraine, these include the anti-inflammatory agents, like we said, the NSAIDs, the 5-HT1B1G receptor agonist, also known as the triptans, and then we see the dopamine receptor antagonists. Okay, the relatively newer ones like the ditans and the CGRP antagonists are available. Right, this is just a schematic showing the chronologic order in which medications were developed for the treatment of migraine. And as far back as 1990, we saw the first triptan, sumatriptan, being approved. And it comes all the way into this recent times, 2020, 2021, 2018, where we've had the monoclonal antibodies, CGRP monoclonal antibodies being approved, as well as the GPANs, which are the smaller molecules of the CGRP antibodies. Right. Okay. So I've already mentioned that there are non-specific therapies like the NSAIDs and also combination of these with aspirin, caffeine, and then there are specific therapies like triptans, ergots, derivatives, the GPANs, and the ditans. Okay. And these have been found to be efficacious. Now, when it comes to treatment of migraine, it's also important to factor in associations and comorbidities. So if the patient has failed NSAIDs or analgesics, then you may think of using the first year some triptans, or if they need slower or better tolerability, then triptan for a triptan may be considered. If they have nausea or vomiting, there are nasal sprays or oral melts that can be given. Okay. If they are menstrually related migraines, then you want to probably consider prevention, short-term prevention with estrogen patches or oral contraceptive pills. Okay, and if the migraines are very rapidly developing, then you might consider parenteral medication with subcut sumatriptan or the nasal spray. Right, so for emergency treatment of migraines, we're looking at parenteral medication. So dihydroergotamine, if it's available, can be given intravenously or IM or subcutaneously. Subcutaneous sumatriptan, 6 milligram, is very effective in about 70 to 80% of patients as well. Right, so it's important to know that drug absorption during a migraine attack is greatly reduced, and this can happen even in the absence of nausea, and it's usually related to the severity of the attack but not the duration of the attack. Now, when an NSAID or triptan have been used and they have failed, then it's important to add on a dopamine antagonist such as metoclopramide, 10 milligrams, and this will enhance gastric absorption and allow the medications to be as effective as possible. Other parenteral dopamine antagonists like chlorpromazine, chlorperazine can also be given. Now, narcotic use as much as possible in migraine should be avoided, except in patients with very severe and infrequent headaches. And when they present to the emergency room with a one-off very severe headache, the headache is not frequent, then we can consider giving IV pethidine, but giving tramadol, Doretta for recurrent headaches should be highly discouraged. Right. So in terms of triptan use, it's important to note the following contraindications. You cannot give triptans to people who have uncontrolled hypertension, if they have ischemic heart disease or any evidence of it on ECG, peripheral artery disease, a history of stroke, history of hemiplegic migraine. We have to be very careful with that one. It's not totally contraindicated, but we need to exercise caution. And it shouldn't be given within 24 hours of giving a dihydroergotamine either. Now, for the acute management of migraine with the triptans, it will be useful to know the onset of action as well as the duration of the various triptans, and that is what has been spelled out here. So in terms of using triptans, it's important to give the triptan early on in the headache phase, within 15 minutes of onset of the headache when it is mild, and a dose starts from as little as 50 milligrams to as high as 100 milligrams. Okay, and this dose can be repeated once to at least 2 hours after the initial dose was given. We should not give the medications more than 2 to 3 days a week, and we want to do this to prevent medication overuse headaches. The triptans may be used concurrently with NSAIDs or opioids and antiemetics that we've already described. And if one triptan is not working, it's always possible to try a different triptan. Medication overuse headache. Now let's segue into this. I've mentioned it quite a number of times in this presentation. It is not a separate headache entity. It usually is associated with primary headaches like migraine and tension type headache, and it occurs because of the overuse of the medications like NSAIDs. If you're using NSAIDs more than 15 days a month, or triptans or opioids more than 10 days a month, then you are predisposed to getting medication overuse headache. It alters the headache severity, intensity, making it very difficult to treat. Now, for treatment, it's important to break the cycle. You need to stop the corporate medications that they are on by doing a gradual taper. The symptoms may worsen, but they tend to get better over time. So it's almost like going cold turkey. The withdrawal symptoms will be nervousness, restlessness, nausea, vomiting, insomnia, constipation. These may last about 2 to 10 days or several weeks. They may require admission during the period where we're trying to break the cycle, and bridging therapy or emergency parenteral treatment may be useful in this setting, as well as prophylactic therapy. It should be initiated when we are trying to break the cycle of medication overuse. It's important to also use non-pharmacological therapies for the acute attacks during this period, and limit the use of the acute therapies to no more than 2 to 3 days per week, as we have been emphasizing in all patients. Now, prophylactic medication is very important for those who qualify because it helps to reduce the attack frequency, reduces the severity and duration of headache attacks, it helps to reduce the need for acute treatment, reduces disability, and overall it improves quality of life. Now, our target is a reduction in the frequency of migraine attacks by 50%. Okay, for those with episodic migraine, and for those with chronic migraine, a reduction of about 30% is considered quite good response. Right. Now, apart from methotrexate, which several years ago was specifically approved for migraine prevention, all the other medications that are currently on the market are used off-label. Okay. Now, to qualify to be on prophylactic treatment, you need to have had about 2 severe episodes or 4 less disabling episodes or 3 attacks per month. If you have acute migraine treatment that is ineffective or contraindicated, you qualify. If you have medication overuse headache, you also qualify. If your headaches are highly debilitating, like hemiplegic migraines or migraine with brainstem aura, you also qualify. Patient preference, that is debatable. Right. So the classes of medications that we use generally as prophylactic medication in migraine include anti-epileptic medications. So we have sodium valproate, topiramate, gabapentin. They can be used. Antidepressants like amitriptyline, venlafaxine, the SSRIs, SNRIs can be used. Then the beta blockers, commonly propranolol, metoprolol, timolol, it can be used. There are also the calcium channel blockers and other antihypertensives like verapamil, okay, like lisinopril, candesartan. The neurotoxins, onabotulinum toxin A, which is usually reserved for those with chronic type tension migraine, chronic migraines, who are not responding to other prophylactic therapies. So if you've used about 2 or 3 of these over a period of more than 3 months, you've changed them every 3 months to a different one because they're not responding, you've done that about 3 times, then they qualify for a trial of onabotulinum toxin. Then our new kids on the block, the calcitonin gene-related peptide monoclonal antibodies. Currently, we only have a Renomab available in Ghana that is given once a month. Subcat is also available. There are other medications and herbal therapies that have been found to have varying levels of efficacy in the management, like magnesium, riboflavin, memantine, coenzyme Q10, and melatonin. Right. So these are the various level of evidences and the doses of the various medications that we have mentioned. So you can take your time and have a look through them when you get the slides. Right. Okay. Now it's also important to consider the comorbidities that patients have before we choose these prophylactic medications for them. Okay, so in general, verapamil, memantine, lisinopril, candistatin, they are well tolerated if the blood pressure is normal. You may want to avoid valproate or puramates, amitriptyline, depending on the age of the patient, whether they are of reproductive age, okay, or if a pregnancy is recognized. Right, so also if the patient has insomnia, you may want to consider amitriptyline or melatonin that will help with your sleep. If they have anxiety, beta blockers, like topiramate, beta blockers will be useful, but topiramate should be avoided. If they have depression, then you might want to consider the serotonin reuptake inhibitors. Avoid beta blockers because they have been found to be associated with depression. If they have hypertension, then antihypertensive medications which are indicated for prophylaxis can be given. You want to avoid the erenumab, venlafaxine, and duloxetine in those with hypertension. If they are obese, topiramate will help with weight loss. Avoid valproate and amitriptyline. Right. So as I mentioned earlier on, about 50%, 75% reduction is considered adequate when it comes to prophylaxis in migraine. Okay, we're looking at reduction in frequency or severity of the headache. Now, once this is achieved, you want to continue the treatment for about 6 months and then slowly taper it. Okay, many patients can discontinue their medications. They will experience fewer and milder attacks with long periods of pain freedom. Right. There are other treatment modalities like neuromodulation, like the electrical trigeminal nerve stimulation. There's behavioral therapy, cognitive behavioral therapy, relaxation methods, etc. Right, and these are nerve blocks that can be given. Greater typical nerve block, onabotulinum toxin A injections can also be given. Right, these are some investigations, therapies that are under investigation as well. Right. Now, in terms of migraine in children, mostly the simple analgesics can be given for acute treatment of migraine. For children above the age of 12, we may consider the use of triptans as well. The different triptans may be given, with the triptan, sumatriptan, and amitriptyline being the most common ones that can be given. And if they qualify for prophylactic medication, we may consider prophylactic medications as well, especially if the headaches are severely disabling for them. It's quite similar to medications that are given in adults as well, especially for children above the age of 12. In pregnancy, let me just say that about half to 3/4 of females who have migraine, they have their migraines greatly improved during pregnancy, but a few, about a third, will have worsening or exacerbation, and this usually occurs in the second or third trimester. Those who have migraine with aura are actually at greater risk of having these more frequent episodes during pregnancy. The prophylactic medications are usually branded category C, D, or X in pregnancy. And so non-pharmacologic options must be used. There's like relaxation therapies, etc. Okay. Now category C means that no studies have been done in human fetuses, but the potential benefit may exceed or outweigh the risk. Category D, some studies have been done on the human fetus. Again, the benefits usually may outweigh the risk, and so it can be given. But category X, we don't have any studies. It should be avoided as much as possible. Right. So once again, for acute or therapy in pregnancy, we are looking at paracetamol. It is safe in all trimesters. NSAIDs can only be used in the second trimester, and the triptans are considered category C. So if the benefit outweighs the risk, definitely go ahead and give it. Sumatriptan is what has been found or has been used most frequently. If you are in doubt, please refer to the neurologist. For preventive treatment, yes, we need to once again weigh the benefits against the risk. Some studies have shown that botulinum toxin may be safe in pregnancy. Right, so contraindicated medications in pregnancy, the CGRP monoclonal antibodies, flonarizine, topiramate, sodium valproate, zonisamide. These usually you will have some kind of teratogenic effect, so they should not be used. Some have not been studied at all in pregnancy. We would rather avoid them. So in summary, migraine can be modified and controlled. It cannot be eradicated. An individualized approach to the treatment is very important. Narcotic use in migraine should be limited to only very severe and infrequent migraine attacks, as much as possible the parenteral in the emergency setting rather than the orals at home. And migraine with aura is associated with a 2 to 3-fold increased risk of strokes, especially when it's combined with smoking and the use of oral contraceptive pills. Women with childbearing age should be counseled about their medication teratogenic effect, especially when we are using topiramate, valproate, etc. And they should be counseled on taking up contraception appropriately. Prophylactic medications reduce the frequency and severity of migraine, so if patients qualify, they should not be denied the prophylactic medication. And these prophylactic medications should not be given as acute medications. They are not. You cannot give somebody amitriptyline to take when they're having an acute attack and you tell them to take for 3 days and stop. No. Prophylactic medications are given over a long period and they are tapered and stopped over about a 1-year period and then reassess if they need to be continued. So now we look at the management of cluster headaches, and once again the management can be divided into abortive or symptomatic treatment, and this is usually with oxygen, triptans, ergot alkaloids, or anesthetic agents. And then there's a preventive or prophylactic treatment where usually would give steroids, calcium channel blockers, etc. There are certain special procedures or surgical interventions that are currently not really used in our setting. In terms of acute or abortive management, oxygen given at 8 to 12 liters per minute for about 10 to 15 minutes or 100% by non-rebreather mask usually would abort the headache if it's a cluster headache within 15 minutes. Okay. Also, we can give the subcut subcut 5-HT1 receptor agonist like triptan. So usually subcut triptan 6 milligram is given, and this may be repeated in 24 hours. Intranasal administration is said to be more effective than placebo, but not as effective as the subcut injections. Other triptans may also be considered. Dihydroergotamine can also be given intravenously. 1 milligram should be fine. Intranasal administration of lidocaine drops, so 1 ml of a 10% solution placed on swabs in each nostril for about 5 minutes may be helpful. The CGRP monoclonal antibody galcanezumab has been effective in management of episodic cluster headache in adults, and intranasal capsaicin has also been successfully tested in clinical trials and it is believed that the capsaicin depletes substance P in the nerve terminals and prevents the reaccumulation. Corticosteroids are also very effective in terminating cluster headache cycles, and they prevent the immediate headache recurrence. High-dose prednisolone is usually given over a period, and it started at 90 milligram and tapered off by 30 milligram every 3 days for another 9 days. Methylprednisolone IV can also be given at the dose of 250 to 500 milligram daily for 5 days, followed by oral tapered dose, okay, over about 1 week period. Right. So we need to bear in mind that corticosteroids, they have side effects, and that is why we give a high dose initially for 5 days and we taper it off. They can come with hypertension, diabetes, water retention, can lead to bone defects, leading to osteoporosis, among other things. So we really need to look at this, as well as the increased susceptibility to infection while they are on it. It shouldn't be something that is given, it should be given sparingly, put it that way. Also, for preventive therapy of cluster headache, we are looking at calcium channel blockers, so verapamil, the commonly used one. It's a dose of 120 to 150 milligrams 3 times a day. Lithium carbonate, this should be used by a specialist, okay? 800 to 1,600 milligram daily. Remember that it has a very narrow therapeutic range, so it should be reserved for the specialist to prescribe this. Methotrexate, like I said, it's off the market. It's not being used anymore. Anticonvulsants like topiramate, sodium valproate, can also be effectively used. There are other interventions like Botox, greater occipital nerve blocks. Some gamma knife radiosurgery can also be used for prevention of chronic cluster headaches. Okay, sometimes there are some stimulation of the sphenopalatine ganglion or the greater occipital nerve have also been tried in practice. Right, then we look at the other trigeminal autonomic cephalgias, commonest or the common ones being paroxysmal hemicrania. So it's almost like migraine, but this headaches are longer lasting. They can last between 2 to 20 minutes per episode. And they have been found to be highly responsive to indomethacin in doses of between 75 to 150. When given as doses of between 75 and 150 milligrams per day, remember the GI side effects of indomethacin, it can cause some gastric irritation leading to ulcers. Then there's the SANCT or SUNA. These are short-lasting unilateral neuralgical headaches with conjunctival injection and tearing and cranial autonomic symptoms. They respond to short courses of IV lidocaine, 1 to 4 milligrams per kilogram per hour. It really reduces the flow of attacks. Lamotrigine, gabapentin, topiramate, and carbamazepine in the doses listed can also be given. Right, so this is a table just summarizing the differences between the different primary headache symptoms, okay? You can take your time to go through them. So I'd like us to look at one last thing. It's a facial pain syndrome. It's not part of the primary headaches, but it's something that patients can present commonly to the primary physician with, and they may be misdiagnosed as migraine, as dental problems. There's so many differential diagnoses for this. Now, trigeminal neuralgia is characterized by recurrent unilateral, very brief, usually less than 1 second to 2 minutes, and very painful electric shock-like episodes. Okay, and it's usually within the maxillary and mandibular divisions of the trigeminal nerve. So it spares the eye, it spares, the ophthalmic division, which is more commonly seen or associated with the trigeminal autonomic cephalgia. So it's important to take a good history to exclude eye involvement, exclude the presence of autonomic symptoms, because if they don't have autonomic symptoms, then you may very well be dealing with trigeminal neuralgia. Okay, it really makes for a poor quality of life with increased anxiety and depression. A prompt diagnosis, investigation, and treatment is necessary. So there's classic trigeminal neuralgia, which is usually caused by a neurovascular compression of the nerve. Okay, and with this, an MRI will be very useful in identifying it. Okay, so that the appropriate intervention, which is usually a surgical decompression, can be initiated. Secondary trigeminal neuralgia. This is usually associated with an underlying neurological disorder like multiple sclerosis or tumors or AD malformation. So once again, an MRI is very important. Okay, remember that usually with the primary headaches, MRIs might not, or investigations, brain imaging might not be necessary unless we are having red flags. But in this case of trigeminal neuralgia, it is important so that we can identify the underlying cause. Then 10% are usually idiopathic. Okay, there's nothing apparent. Imaging usually will come back normal. Right, so physical examination is generally normal, but 30% of cases they may have sensory changes like hypoesthesia. On rare occasions, ipsilateral facial muscle contraction may be induced by the painful spasm attacks. Right, and this is a list of differential diagnosis of trigeminal neuralgia. You can see there's a broad list there. There are dental problems, sinus problems, salivary gland problems, temporomandibular joint problems, neuropathic pain. So many of them post-herpetic neuralgia comes in here. So many trigeminal autonomic cephalgias are also a differential diagnosis. Right, and we've already gone through how to differentiate them from the other attacks. Right, so when do you refer a patient to the neurologist? When you are in doubt, you're not sure if it's a secondary headache or a primary headache, please refer. For complex headache cases that you're finding it difficult to manage, patients with suspicion of medication overuse headache, those with progressive non-responsive to treatment headaches, please refer them. Right, I hope that I've not given you a headache with this lecture, and we can zoom into case discussions. Right, okay.
Thank you very much, Dr. Glover. Indeed, some people are having headaches, and I hope that you have a way of managing it for us. Thank you very much, quite extensive. And as I said, the slides will be shared so that if you would need to go over to get certain parts, well, but there's also going to be chance for questions. So all your questions, the difficult ones, please. I'm not a neurologist, so don't reserve your questions for me on word rounds, please. Dr. Glover is here to answer all of them. So thank you very much, Dr. Glover. As I said, we are privileged to have our partners here with us, Novartis and Johnson & Johnson. And these groups are specialized in having medications that help with most of these primary headaches. So just before the questions will come in, we'll be having a presentation, but I'm sure those with the National Science and Maths Quiz Group will want to check whether your answers were right. So Dr. Kwabla will go through the answers to the questions that were asked. And I'm sure when it comes to the question and answer time, Dr. Glover will give some small expansion on the answers. So Kwabla, can you please go through the answers? And please do mark, so don't bring me your marks, but please mark yourself and keep it.
All right, so we are going to go through the answers for case 1. All right, so diagnosis, chronic paroxysmal hemicrania. Treatment that was given. Initially, 25 milligrams of indomethacin was prescribed, but produced no response. However, 75 milligrams 3 times per day resolved the pain completely. On this regimen, even with a proton pump inhibitor, Jamie developed gastrointestinal distress that was intolerable. She now takes indomethacin 25 milligrams in the morning and then 75 milligrams at dinner. She adds 50 milligrams suppository as needed when attacks are particularly intense. Jamie describes this regimen as 75% effective. The commentary, so paroxysmal hemicrania is a rare primary headache in the family of trigeminal autonomic cephalgias. Paroxysmal hemicrania is important to recognize because it is exquisitely responsive to indomethacin. Other treatment options include verapamil, topiramate, and lithium. Then the answer for case 2, the diagnosis was severe unilateral neuralgiform pain with conjunctival injection and tearing. The commentary, so also TACs, severe unilateral neuralgiform pain with conjunctival injection and tearing, and its cousin, short-lasting neuralgiform headaches with cranial autonomic symptoms are rare, with a prevalence of 6.6 per 100,000 persons and an incidence of 1.2 per 100,000. Distinguishing features of SUNCT include very short duration, side-locked, excruciating pain attacks with a reddened eye, tearing, or both. Typically, attacks can occur 10 to 400 times per day, and unlike cluster headaches, there's no circadian pattern. The first division trigeminal nerve distribution, prominent autonomic features, and lack of refractory period readily distinguish SUNCT from trigeminal neuralgias. Thank you.
Thank you very much, Dr. Kwabla. I'm sure those who had it right know. And if you know you didn't get it right, the slides will be sent again, because I think Dr. Dotlova went through that aspect again. And it's good that as primary care physicians, we get to know some of these things. Because if you're going to send all these cases to Dr. Dotlova, I'm sure he wouldn't close her clinic most days. So please, that's why we're having this presentation, so that all headaches will not be typhoid, and all other unilateral headaches will not be migraine, so that at least you can have the different types and know how to manage it. To have the presentation for Johnson & Johnson, we have our good friend and pharmacist, Mr. Kofi Teria Edu. He's a product manager with Johnson & Johnson Ghana. Kindly, let's have him as he gives us a presentation on Topamax.
All right. Thank you very much, Your Excellency. So he's my president, so that's how I refer to him. But before I even delve into today's topic, Johnson & Johnson is a global company, and meeting family physicians, we would want to also introduce what we are doing in Ghana currently. So currently in Ghana, we have about 5 portfolios that we have brought into the country. And I would like to just introduce them to you. First and foremost, we have our oncology portfolio in Ghana now. And within that, we have a prostate cancer medication called Zytiga, acting as abiraterone for prostate cancer. So that's what we are doing for oncology now. As the years go by, we are looking at introducing new molecules into the country. So for oncology, we have Zytiga. And then for hematology right now, we have Velcade in country for multiple myeloma patients. And also, we also have immunology portfolio. Within that, we have Remicade, that is infliximab for IBD. And within that, we also have Symphony for rheumatoid arthritis. So that is what we have for the immunology portfolio. And finally, as for the CNS portfolio, which we are really focusing on currently, the innovation that J&J is bringing is that we have a drug called Invega Sustainer. It's a 1-monthly injectable for schizophrenia. And also just late last year, we introduced Trevicta. It's a 3-monthly injectable for schizophrenia as well. So for that product, you just take 4 injections within the year for schizophrenia patients. And for our more common portfolio, we have Verbox, Pariet, and then 2 products that I would like to talk about next. I would like to first and foremost thank all the speakers, Dr. Damoa, Dr. Oglova, and even my colleague from Novartis, Obo as well. I think that there has been a lot of conversations on how migraine impacts patients and what needs to be done as clinicians and as the healthcare team to help manage patients who are on this, who have this condition. So clearly, the image is clear that imagine having less of the lady on the left and more of the lady on the right. Clearly, it is a very debilitating condition, and we are looking at ways to manage it and have options. The goal for the pharma companies is to provide options for clinicians. so that you're not stuck on one medication forever, that we can have more innovation, and then our patients are very topmost goal, and we want to give them the best quality of products as we can. So for J&J, what we have for migraine is Topamax. I think Dr. Odlova mentioned a number of times in her presentation. Our brand is Topamax. It's a pretty common medication, so to speak. It's been used over the years for epilepsy for a very long time for seizures. But in 2004, it was approved for migraine prophylaxis. So in that, it's a neuromodulator with stabilizing properties, and it's been approved for migraine prophylaxis in over 59 countries globally. And currently, we have more than 4.3 million patients on Topamax worldwide for migraine prophylaxis alone, not for the epilepsy. Just for migraine prophylaxis, we have about 4.3 million patients on Topamax. So the mechanism of action is quite simple. It blocks sodium channels, limiting repetitive firing. I think there was a lot of mention of the trigeminal nerve. It reduces the activity of calcium channels as well, and it will help stabilize the trigeminal nerve to break the perception of pain. So it is just to reduce the pain or help break the perception of pain. And it is for migraine prophylaxis, not for acute therapy like Dr. Glover has already mentioned. It is for prophylaxis as well. So I think that there's been discussions on what is a good prophylactic treatment and what it would be in for your patient. It has been shown over the years that it has been effective in rapidly reducing migraine for your patient. It is able to do over 50% reduction of monthly migraine attacks for more than half of the patients. That is, after a 6-month treatment, you can do as well as % or more when it comes to the migraine attacks. Yes, and this was based on a 6-month open label extension of 6-month double-blind placebo-controlled trials. And this is what the outcomes were. The conclusion was that if you give Topamax to your migraine patients, you would have about 50% reduction in the number of migraine attacks for more than 50% of your patients. And hence, it falls within the selection of very good prophylactic medications for your migraine patients. All right. So this further establishes the point that I was trying to make concerning the efficacy of Topamax as against placebo. So there's been studies to show that there's a great reduction in the number of migraine days for patients who are put on Topamax as opposed to your placebos. And the greater number of days on acute medication as well is reduced. So the essence of using Topamax is not just to reduce the number of attacks, but also to reduce the number of times your patients will use prophylactic or the acute therapy for migraine. Usually, acute therapies are used when the patients have the attack. And when you are preventing the number of attacks within a month, they end up taking less of the acute therapy. And that is what Topamax provides your patients. And that is clearly stated earlier. Medication overuse headache is a very common condition that happens to patients who are constantly taking these pain relievers. And hence, the ability to reduce the number of times the patient is getting the attack, which would lead to the reduction of the number of acute therapy, would prevent this condition of medication overuse headaches. So there's been the conclusion of that study was that there's been sustained benefit, which was reported after discontinuation of topiramate. So usually, because it's a prophylactic treatment, they want to take it for a long time. There's been studies to show that if you take it for 6 months or more, it is safe, and that you can even take it to up to a year. That slides. Okay, go back, please. Back. Yes. So the findings suggest that patients should be treated for at least 6 months with the option to continue to 12 months in some patients. So it is safe in using it for 6 months or even more to up to a year when preventing migraine attacks. And also, I think that the adverse events of these kind of medications are very important. So there's a study that showed, showed the rate of discontinuation of topiramate against placebo. And it looked like at the side effects. And the most common side effect of Topamax is paresthesia. That is the numbness, tingling, and then of the extremities. However, the discontinuation of this due to these effects was about 5% total. Out of all the patients that we had globally, just about 5% of them were discontinued Topamax use because of the side effects. And some of these other side effects, as I'm going on, constitute fatigue is one of them. There's anorexia, there's nausea, there's taste alteration, there's somnolence, difficulty with memory as well. but these is in a smaller percentages as compared to some of the other placebos that we have on the market. So with the dosing, I think that is where we like to communicate more on. For migraine prophylaxis, where you start from is the lowest dose. When you are giving migraine Topamax to your migraine patients, you start at 25 milligram once a day at night for a whole week, and then you titrate up to a targeted dose of 100 milligram twice daily in 2 divided doses. So this is how it goes. For the first week, you do 25 milligram at night, and then the second week, you do 25 milligram in the morning, 25 milligram at night. Third week, you do 25 in the morning and then 50 at night. And then for the fourth week, you do 50 morning, 50 at night. And then you maintain the patient on that dose till you decide to taper them off. It is important to know that you have to taper the patients off Topamax. You don't have to stop abruptly because of the way the medication works. All right, these are some of the information that we would like to share. There are 10 special warnings. Hydration is very important when you are giving Topamax. Weight loss is a side effect that we mentioned for Topamax, but there's been instances where people who want to lose weight actually go for Topamax, even though they don't have migraine. And we really speak against that. It is not a drug for weight loss. But if you have patients who are obese, who have migraine, then it would be a best bet for them so they don't gain extra weight when they are taking their migraine medications as well. And for oral contraceptives, when you are taking them in addition to migraine, there will be a reduction in the efficacy of your oral contraceptives. And this is a very important information to give, because if you have a woman who is trying to avoid pregnancy and then they decide to add Topamax to their medication, what will happen is that they might actually get pregnant because the oral contraceptive will not be very effective because they are adding Topamax to that medication. I think common side effects, like I said, weight loss, paresthesia, drowsiness, and dizziness. And it is contraindicated in pregnancy as well as children under age 2 and patients who are also lactose intolerant. Dr. Stephen D. Sebastian is a neurologist, and in April 2004, he stated that based on its efficacy, which is Topamax, and tolerability profile established from its use in patients with epilepsy, Topamax should be considered as one of the first-line treatment options for the prevention of migraine headaches for your patients. So that is a quote from Dr. Stephen D. Sebastian. And still back to this image, we are looking at imagine less of the uncomfortable situation where your patients cannot function properly to this picture where they can actually play with their family and then have a much better quality of life for them. Thank you. But I would like to share, go on. These are the references that we used. But most importantly, with Johnson & Johnson, we are very concerned with safety and feedback from clinicians. So we have an entire safety team that would, respond to your queries concerning the safety of the medications, including product quality concerns and anything that has to do with adverse events. So these are emails that we have and numbers that we have that you can reach to us on. That is the emails and then the phone numbers as well. Or even if you know any Johnson & Johnson employee, you can reach out to them and then report the concerns you have when it comes to any of our medications, not just Topamax, any of our medications that I've already mentioned. If you have any concerns, kindly reach out to these emails and also the phone numbers. Thank you very much for your turn. I'll take any questions. All right.
Thank you very much, Kofi Teria Edo, for your presentation. I mean, I can see a lot of questions coming in on this medication. So, because I think that headaches, especially primary headaches, is a very big concern for a lot of primary physicians, and especially where to get some of this medication. So please get yourself up for the questions. So it's question time. And Dr. Baba Damoa. So somebody is actually listening to us and saying that, I mean, sometimes it's very difficult knowing whether it is a primary headache or secondary headache, especially as I said, for most people, if you bring headache, it's malaria or typhoid, and especially typhoid. So you come with headache, you go on with Cipro. And it's asking, how would he be able to differentiate between primary headaches and secondary headaches so that, I mean, especially a lot of, primary physicians, so that at least they don't go, by always prescribing medications that are not useful. Your question.
Okay, thank you very much. First of all, you as a primary caregiver, you have to use the current diagnostic criteria to define your primary headache. And I went through that using the International Classification of Headache Disorders version 3. After you have convinced yourself that this fits a migraine or a tension type headache, you consider the patient as a whole, and you want to also screen for secondary headaches. The reason I said it, like I said in my presentation, primary headaches, though it affects their quality of life, occupation, socially, and all that, they are rarely fatal. But secondary headaches are. So you want to go through the SNOOP acronym. Look for systemic things such as immunosuppression. Is the patient having weight loss? Is he having projectile vomiting? Is the patient having severe hypertension? You want to also screen for neurological things. If somebody comes with a headache and is having seizures as well, you obviously will have to go ahead and do some sort of imaging for such a patient. You want to check the onset of the headache, whether it's in a child less than 5 years or in somebody above 50 years, whether the symptoms starts and peak within a minute. And then also check for precipitation, things like whether it is precipitated by cough, whether this patient is pregnant, is in the postpartum period, does the patient have papilledema. All these signs and symptoms make you screen and differentiate between primary headaches and then secondary headaches, which will go to help the patient. Thank you.
Thank you very much, Dr. Baba Damoa. Dr. Glover, I think this one is coming to you. So we're having this trend where everybody that entered the primary care, clinic with headaches goes with a request for a CT scan. And these days, people are even going for MRI. Could you give us an advice as to when, in terms of trying to manage somebody who comes with headache, when do we request for a CT scan? CT scan cost can be somebody's monthly salary, and MRI probably twice somebody's monthly salary. But for us, sometimes they come, they are holding their head, and it's like, this person needs an MRI. Can you please help us with when, from your where you stand? That
right, Dr. Nketia. Thank you very much. Am I audible? Am I audible?
Very, very audible.
Thank you. All right. So it's a very important question, and I think it needs to be addressed. Dr. Damwa did a very good job going through the IHS criteria for the various primary headaches. I know it can take a while to sort of get it at the fingertips, but it's a learning curve. You don't need to cram one day at a time. Every time you see a patient, you can refer to the different headaches, and then it sticks. Okay. Once you are able to fit these criteria into the headache, so the history is very, very important. If you're able to fit the criteria of the different primary headaches into the history that your patient is giving you in your examination findings, it's very likely that it is a primary headache that the patient has. If the patient has any single SNOOP symptom, then you're worried and you want to rule out a secondary headache, because secondary headaches can present with morbidity and mortality. So those are the instances when we want to do imaging. But if it's purely a primary headache, you've seen that there's nothing else that explains those symptoms that the patient has. It's following a certain pattern that looks like a primary headache, then it's a primary headache and it doesn't need investigation. Okay. I mentioned that facial pain, like trigeminal neuralgia, because of the distribution, if you're able to take a very good history and you realize that the ophthalmic division is not involved, there's no associated autonomic symptoms like, conjunctival injection, tearing, lacrimation, nasal congestion, then you know that it's just trigeminal neuralgia involving the maxillary and mandibular divisions of the trigeminal nerve. You can go ahead and do imaging, because we said that there's the classic one where there can be something compressing on the nerve, or a secondary one where there could be multiple sclerosis, and it could be a first presentation of multiple sclerosis, or there could be a tumor in the brain. So for that circumstance, you need to get brain imaging done. And any of the SNOOP symptoms and signs, when they are fulfilled, then your index of suspicion for wanting to get neuroimaging done, that one goes up. Okay, so That's the comment that I would have to make about that. Don't request MRI or CT scan for every single person that comes to your clinic with a headache. I'm not sure how many of us will be able to afford those images. Thank you.
Thank you very much. I think this note I'll be putting some pen and papers at the diagnostic centers. When we review and it's not, we come for the money from the clinician. So to Novartis, a very interesting question here. So somebody's asking, we've talked about Pazuta, a very powerful name. What's the composition of this? That's the first one. Then the next one, can it be used in children and adolescents? Because we're having a lot of adolescents with, this kind of primary headaches. And you've made a nice presentation, but at times when most of our people who are listening to us or are with us are in the districts. Over 1,000 audience listening to us at the districts. Can they get it at the pharmacies near them? And at what cost? Remember that my grandfather, my cousin is, my uncle is a farmer who lives at Kokotro, and probably my cousin may have some primary headaches and may need it. Can they get it there, and what's the cost? Thank you.
Okay, thank you. Yes, so the composition is erenumab, and I also saw it on a couple of slides that came around. So it's a monoclonal antibody, and it's the first of its kind to be approved in Ghana. It was approved in 2019. Yes, 2019, right before COVID. But in Ghana, we got approval in 2021, and we brought it in since last year. We launched it last year, sometimes last year. It's readily available. Currently, Ozone's Chemist is our wholesaler. So if you need it, you can call me as I flash my number on the screen. Or you talk to us. We'll get Ozone's Chemist to bring it to your doorsteps. Just yesterday, we got 3 patients in Kumasi. So Ozone's Chemist dispatched it to the patients, and then they've taken their jabs. I think the other question has to do with what age. So from 15 years and above, you can take Pasuta. No, not below 15. Right now, we don't have the study in 12 years from 10 to 15 is now ongoing. So once they are done with the study, we'll get to know. But from 15 years and above, you can also take Pasuta. And the price, a jab goes for 4,200 Ghana cedis. And of course, a jab goes for 4,200 Ghana cedis. Yes, for a month. And of course, like I said earlier, if you look at the impact on quality of life for these migraine patients who may lose 15 to 20. In fact, there was a patient who loses 21 migraine days every month to, who loses 21 days to migraine. So of course, if you find those patients who may be able to afford, who are within that bracket, don't always also extend the benefit of Pasuta to them so that they also be able to get the medication. We are working on some patient support programs. Once we launch them, I'll reach you with how we are also able to support our patients who may not be able to afford the molecule. Yeah. So I'll reach out to you when we're able to launch. When we launch those patient support program. But if you see the doctors, the pharmacists like myself, and the nurses, and of course the ministers, kindly do extend the benefits of Pasuta to them. Thank you.
Thank you very much, Wisdom. So to Johnson, a question that is coming. Topiramate has been around for a very long time, being used for prophylaxis for a lot of these paramedics. But somebody is asking, now they have been bombarded with a number of primary headaches. Which of them specifically, can topiramate be used for?
Yes, thank you. Thank you very much, Dr. Nketia. So for us currently, it's been marketed for migraine prophylaxis. But I think that's from Dr. Glover's slides. He did mention that sometimes cluster headaches, they use it. But for us, it's for migraine specifically that we are using it for the prophylaxis, migraine prophylaxis. And the price is 400 cedis as compared to 500 cedis for a month. The 50 milligram goes for around 400, and then the 25 is around 300 to 320 cedis for a monthly supply of 60 tablets. Thank you.
Okay, thank you very much for this information. So he's saying that specifically, on their portfolio indicated for migraines, but it looks like Dr. Clover is trying to market it for them for cluster headaches. So
Hey, I am not doing any marketing.
no, when you're at that place, come for your, they're going to pay you for that one. Just by the way. So another question is coming to Dr. Baba Damwa. Somebody is saying that can migraine cause numbness and pins and needle sensation to the side of the head? So this is for you, Dr. Baba Damwa.
Yes, it can. If we go through the aura symptoms I described, you realize that we have sensory aura. And for that, they may have auditory or olfactory hallucinations. And aside that, they may also have paresthesias, pin and needle sensation, hot flashes along the side of distribution of the nerve. So yeah, it's possible.
Okay, thank you very much. There's this other interesting question that is coming. I think we have a lot of questions on the Pazota. Can it be used in pregnancy?
Thank you very much for the one who asked. So for now, we don't have sufficient data for it to use in pregnancy. So the answer is no, it cannot be used in pregnancy. Then also I wanted to clarify something. I think I didn't highlight it well. Pasuta is not, once you diagnose a migraine patient, you don't start off with Pasuta. So it's for patients whom you have tried at least one or more medications and the patient has failed. So if you have any patient who is failing on one or more medication, then you can initiate Pasuta in those patients. Thank you very much.
Yeah, thank you very much. Dr. Glover. So somebody's asking that, from your presentation, you said tramadol is not the best. In fact, I've had a lot of people who have tried that and got addicted to it. So, I try to stand with you on that. But somebody's saying that, that's what they are used to. And if it's been discouraged, then triptans are also not very readily available to them at a lot of the facilities at the districts. It's good to know that most of the people listening to us are across the country. So they're saying that what are the other options that are there to be used for?
Yeah, great. Thank you very much. Yeah, so you see, this is why I said that the principles of management in headaches is education, education, education. We are here to learn and unlearn and relearn. So the fact that we've seen seniors, our colleagues using tramadol all the time to treat headaches does not mean it is right. And it's exactly because of medication overuse headache and the fact that they develop tolerance to the medication and they need higher doses and the medication is not working, so they get into this vicious cycle. That is why medication overuse headaches happen. And then their migraines get worse. They don't get better on the tramadol. So that's why we need to limit the use to only people who have very severe and infrequent headaches. Not to mention the fact that it can cause constipation, respiratory, depression, etc. Okay, yes, I agree that the triptans might not be readily available everywhere, but triptans are not paracetamol. They are not over-the-counter medications that anybody can go and buy. Remember the contraindications I mentioned? There is uncontrolled hypertension. Triptans work by causing vasoconstriction. You can't just prescribe it to anybody. You need to work them up, make sure that they don't have those risk factors. Okay, ischemic heart disease, previous stroke. If you just dole out triptans like you're doling out paracetamol, you're going to cause a lot of issues. You're going to give people strokes, heart attacks that they don't need. They only came with a headache. Why are you giving them those things? But yes, they are available when the patient really needs it. Okay, so the patient is not responding to the simple analgesics, ibuprofen, paracetamol, then we can prescribe. And there are places where these medications are available. I have a lot of patients that are on different types of triptans. There are some that are not as commonly available, that like rizatriptan, naratriptan, but they are still available. There are certain pharmacies that stock these. So please, you can reach out to me if you have a patient that needs these, and then we'll see how we can work around it. Thank you.
Thank you very much, Dr. Glover. So, I mean, he's saying that we can use the NSAIDs. Then, if you think that it's not, and if you're having some struggles, she said that she's always available, just that her number is not readily available. You can always get it through me. So, if you need to get to a place, can go through me with some little consultation fee. Dr. Babadama, so this coming to you. Somebody is saying that he's been getting a lot of patients who are coming to him. You know, the economy is not, easy, and people go hungry. And when they're hungry, they may have some headaches. And he says that, what is this one? Is it hunger-associated headaches, or what do we call this one? Or economy-associated headaches? Please, what are the types of headaches that are associated with hunger? Thank you.
All right. So, you realize from my presentation that diet and dietary factors actually are triggers or risk factors for migraine headaches, and then also for tension types headaches. So specifically, food relation and things like that can actually trigger tension headaches, which I remember saying that is the commonest primary headache, as high as 90%. And almost everybody gets a tension headache one way or the other when they are hungry. So they can be risk factors for it. But aside that, when one goes hungry, we, as medics, we know there's hypoglycemia, the sugars have gone down, the brain needs glucose to work. So all those mechanisms can also set in to give headaches. Like if you remember my slides on the mechanisms of headaches, which I said are poorly understood, but there are various postulated theories as to what causes headaches. So they all work together to bring about the symptoms of headaches.
Thank you very much, Dr. Damwa. Dr. Clover, so this comes to you. So somebody is saying that we've been talking about prophylaxis, and here you mention about the Botox injections. Can you kindly elaborate on it, how it can be used for prophylaxis? Dr. Glover, please, are you on?
Can you repeat the question again? I didn't quite.
Okay, sorry. So somebody is saying that you've talked about prophylaxis for migraine and a number of things that can, but one interesting thing that passed, that he heard of was the Botox injection for prophylaxis or intervention.
The Botox, yeah.
Yes.
Mm-hmm.
And can you elaborate on it for us?
Yes. Right. So the Botox, we know that Botox is usually used in the cosmetic world, and it causes muscle relaxation so that wrinkles are not so apparent. But that is not the reason that it is given in migraine headaches or any headache for which it's used. What it does is that so this was actually how do I say it? A coincidental finding that they found with people that were getting these treatments. They found that most of them came back and said that their headaches had disappeared. Okay, and it's because the Botox prevents the release of these neurotransmitters that we spoke about earlier, the substance P, the CGRP, all those things. It prevents their release at the nerve terminals so that you're not getting the headache. And usually it's given once every 3 months, and there are about 31 injection sites on the head and neck region using an insulin syringe. Okay, that's how it's given. And once it works, they can come for it every 3 months. Some people might develop antibodies to it, and at a point it doesn't work anymore.
Thank you very much, Dr. Glover, for your answer. So we have over 30 people in here, in-house, and I think some of them have some questions, and I can see a lot of people writing their questions. So On the floor, please, if you have any question, you can kindly lift your hand so that we can give you the mic. Or all your questions have been answered. Any question from the floor? No questions. Okay. So we don't have any question from the floor. It looks like our online participants have asked all their questions. Okay, so there's one here.
Okay, thank you. My name is Dr. Tosu. In the presentation, I was hoping to hear occipital neuralgia. So I get patients, I've had 2 cases like that I researched and I got. So there's pain around the back of the head, occipital region, radiating to the forehead around here. And then it's usually triggered by a touch, combing, or probably lying down. Is that a class? Can it be classified as primary or secondary? And how do we go about management?
All right. So according to the International Headache Society, I said headaches are classified into 3. The primary headaches, the secondary headaches, and then the neuralgias. So that forms the other cranial neuralgias and facial pain. It forms under them. And that's also, that goes beyond this presentation, as this presentation focuses on primary headaches. But like you're saying, it's an important thing because it's a headache. And I'm glad you were able to pick it up and then manage the patient appropriately for it. So kudos.
Thank you very much. I think the last one will go to my good friend, Kofi. So, I mean, when we talk about weight loss, people are really alert because these days we don't have people, doing the lifestyle, exercising and all that. So, the minute you mention weight loss, somebody's coming that he missed that weight loss. And could you elaborate a little bit better, about it with respect to topiramate?
It's just one of the adverse or side effects of taking topiramate. There's not really an indication or a contraindication. It's just that when you are on Topamax, you tend to lose weight. So for patients who are obese, migraine patients who are obese and also want to qualify for prophylaxis, it seems to be one of the best options for them. So they don't gain any extra weight because some of the other medications for prophylaxis tend to cause weight gain. So that is the benefit. It's a side effect, but it can also be a benefit for who, it depends on who you are dealing with. So that is what it does. It doesn't cause weight gain. Thank you, Doc.
Yeah, thank you very much, Kofi. Wisdom, you scared somebody out there with your 4,002. So the person is coming back and asking, how many jabs do we need for the 4,002? Is it monthly? Is it 2 monthly? Is it 3 monthly? Is it 6 monthly? Can you please elaborate on it?
Thank you very much for the question. So it's 1 jab every month, and the patient takes it. I mean, we have trials of patients who are on it, who have taken it for 5 years. And then, like I showed in the clinical trials, we had about 25 patients having migraine-free days, patients who had chronic migraine, so 15 and above. And then after taking it for 16 months, they were migraine-free. So the strategy we are using usually is you inject, and then the ACPs, maybe after the first 3, the ACP analyzes whether the patient migraine days are significantly go down. Then you can let the patient miss a dose or 2. But the more you stay consistently on Pasuta, the more you benefit. The more you stay on it consistently, the more your migraine days significantly reduce.
Thank you very much. For my speakers, I have here Dr. Baba Damoa. I have also Dr. Don Clover. I have my partners from Novartis and also from Johnson & Johnson. We really appreciate your presence and your input. For my in-person audience, I say thank you very much for coming. I was going to say that, definitely there's going to be some questions in the final exams, but really appreciate you coming. Our online audience, over 1,000 who have joined in, we really appreciate you joining us. And we hope and believe that we are benefiting from these programs and it's going to change our practice at the primary care level. I really appreciate everybody, my IT team. I really appreciate you. It's been consistent and it's been smooth. And I'm sure that everybody who have joined us over the past few weeks will say that, yes, the IT section have been fantastic. Really appreciate your input. I want to say that the series has not ended. Next week, Tuesday, on the 12th, we are going to have a major stakeholder engagement. We will stream it online. Just look out for the link so that you can join in. We are going to discuss the topic strengthening primary care to achieve universal health coverage. We'll be looking at the network of practice, how all this could be involved in achieving that. On the 14th, we are, I think on the 14th, that's when we are having the stakeholder engagement. So Tuesday, next week, Tuesday, on the 14th, that's why we're having the major stakeholder engagement. On the 15th, we are having a major big outreach in the Eastern region. We are looking at over 1,000 people benefiting from it. It's going to be medical and surgical outreach. As many that can join us there. It's a way of giving out to the community. So if you can't join us at TAFO next week, Wednesday, Friday, from 8 to 5 at TAFO, kindly join us. Let's give out to the society. 16th, we are moving to Koforidua for, to climax our AGSM activities, and everybody is invited. The rooms have been booked. The rooms are getting finished. You need to book early so that I can have a place. It's going to be an interesting one. Please look out for all the activities that will be going on during the period. Once again, I want to say thank you very much for joining us. And during the 16th to 19th, we're going to have 2 CPDs also that will be streamed live. One on the 16th, 4 to 6, where we are going to look at current trends in management with anticoagulations. And on the 18th, between 4 and 6, we're going to have research methods by Dr. Roberta Lamte and Professor Obineje. Kindly join us, with these ones as well. I'm sure it's going to benefit all of us, especially primary care providers, as we try to utilize data, in our research. Thank you very much once again. We appreciate your presence. We appreciate you joining us. We meet again next week, Tuesday, for our stakeholder engagement. Look out for the link. Join us for this very interesting discussion. We're going to have Director General of the Ghana Health Service being with us. We're going to have Dr. Brichum, Director DDPM with us, and also Dr. Ofebuedu, Director Institutional Care. And our own Professor Esuman is also going to be with us. Kindly join us on Tuesday as we delve into the discussion. Thank you very much and have a nice evening.